My name is Dr. Maheen Adamson. I'm a neuroscientist by profession, and I also have a master's in healthcare leadership, which allows me to say that I have built centers on traumatic brain injury and rehab, as well as now I am currently the research director for a congressional mandated center for women's health at the VA Palo Alto. And it's a very special women's health center because it looks at the impact of environmental and physical trauma and exposures on women veterans. So I'm very heavily into veteran health, but I also study a lot of civilian issues as well. I'm a clinical professor of neurosurgery at Stanford University, but I am a traumatic brain injury expert, if there is such a thing, but more from a veteran point of view and more from a scientific point of view. So I'm not an MD, I'm a PhD. So those are some of the things that I wanted to put forward up front, because my research for the past, I would say, 12 to 13 years or 15 years has been on traumatic brain injury, but I also study all the things that come under it, which include cognitive decline, any kind of cognitive problems, depression, anxiety, fatigue, headache, and I'll tell you a story about how it happened and how I have moved forward with it. People always ask me why I have gotten into traumatic brain injury, and one thing was, when I started being at my postdoctoral fellowship at Stanford, I was doing work in cognition and Alzheimer's. And the reason I went into traumatic brain injury is, one, it was something that VA wanted us to do at that time because veterans were going through some major problems dealing with traumatic brain injury. But my own personal experience with traumatic brain injury is not with myself, but with a cousin of mine who actually got hit in the head. I don't know if any of you watch cricket or have ever heard of cricket. It has this hard ball. It's made out of wood. And he was only 12 years old, and he got hit on the head with it. And this is way back in 1996. And he was 12 years old, and he had a huge subdural hematoma, and he died the next day. So that was my personal experience of traumatic brain injury, and I was 16 at that time, I think. I was 16. This is like 1996 or something. And then so that was my personal experience of traumatic brain injury that I will never forget. And this is not here. This was in Pakistan. And in those days, this was not... And it didn't hit me until later when I started studying neuroscience and what it means to actually, do anything with traumatic brain injury. So at this point, I'm going to go and I'm going to start my slideshow. So currently, I think you guys can all see this. So before I start, I just want to say that these are the things that I just said to you about Stanford and VA Palo Alto. I also want to say that I am a CEO and founder of SOOF Solutions, which is not what I'm going to talk about, but if anybody wants to know, they can type it up in Google and look me up. It is a digital health AI mandated solution that I do for communication, for stroke, and anyone who cannot speak. So we used iPads and use the camera and iPad, and we do gaze and head tracking, and it can help people communicate between patient, provider, and caregiver. Everything that I'd say today is going to be completely my view, not the reflection of Veterans Affairs, Department of Defense, or Stanford University. And my biggest thing that I'm going to say is that I'm CEO and founder of SOOF Solutions, but I'm not going to talk about that today. So this is the only slide that I have on what brain injury is, and I have some examples of it, not all of them. There's, sports, there's car crashes, there's falls, there's being hit, and then the one that's in the middle of here is the one that I talk about when I work with veterans. And the thing that I want you to know here is blast wave comes at you at 26,400 feet per second, but you're running at 22 feet per second. So you cannot escape it. and it comes to you from under the ground through the air. So it comes from the earth, it comes through the air, and it can also have all this debris, and it can have displacement and collapse of the building. So there's a lot of things that are happening inside your skull, and your brain is moving in various directions. And it is the thing about traumatic brain injury that has always been very difficult for scientists to handle, is that it is a very heterogeneous thing. So you can't really pinpoint unless you have a specific area that's damaged because you either have a neurological developmental issue or something that's organic that has grown, or you've fallen on a specific site, or you have been hit on a specific site. Even then, there's trauma that can travel through because as you know, the brain is all connected. So trauma can travel through the fibers to different parts of the body. So what I'm going to talk about today is what's called repetitive transcranial magnetic stimulation. And this is something that it's getting a lot of what we call press. And it is quite something in the sense that we now offer it within the Veterans Affairs in many clinics, and it is given to veterans as a clinical treatment for major depressive disorder. It is also FDA approved for obsessive compulsive disorder as well as nicotine cessation. I have used it for pain. I have used it for depression. I have used it for cognitive improvement. I've used it for headaches. I have also used it for I have personally not used it, but it has been used for anxiety and PTSD. And these are off-label uses used in research. So what exactly is it? So I think what's really important about this is that people always compare it to something called ECT, which is electroconvulsive therapy, right? ECT was done way back when and got a really bad name because it had some issues with it. This is magnetic. So what that means is that, and we've really worked hard to make it in the old days, which was not too far away, it was probably 5 years ago. You went through what's called a month-long treatment, or I would say maybe 2 months long sometimes, like one treatment a day, and you got you got 5 weeks or 6 weeks. So we've really worked hard to shorten it so that it's easier for people to come in and get it done. So when I told you that I do this for depression and pain and everything else, I want to reiterate that all these outcomes that I'm looking at, improvement in cognition, improvement in depression, improvement in pain, is all under the umbrella of traumatic brain injury. So all my patients have to have mild and moderate traumatic brain injury. I have not worked with severe traumatic brain injury patients for this particular technology. And there are ways to do this technology if you have severe TBI. But the key thing is that if you see this little coil that was actually in the previous one as well, right? So that's from my machine down at VA Palo Alto. So this is an H-shaped coil. It's basically an electromagnet that we put on top of your skull. And what it does is when we do it fast enough, it creates a field, an electrical energy within the insulated coil induces this MRI strength field. So imagine that on top of your head, when you keep it there, it will create a field on top of your head that is similar to like a magnetic field, like an MRI strength field, like 1 Tesla or 1.5 Tesla or 3 Tesla. Now, that magnetic field can pass unimpeded through the cranium for 2 to 3 centimeters. Now, this is for areas that you want to look at. So the most important thing is in turn, it induces an electric current in the brain that stimulates the firing of nerve cells and the release of neurotransmitters. And here's a cute diagram of it. And there you go. So when you have electricity going through the neurons, you have the synaptic cleft. I go like this because this is the presynaptic and postsynaptic, and you have the middle area is being filled by your neurotransmitters that have been induced by the electric current, because from the magnetic stimulation it changes into electric current. Now what's important about this is location. Dorsolateral prefrontal cortex is one of the newest parts of the brain. it is an area of the human brain that kind of coordinates a lot of the stuff that's happening in the brain. And it seems like this area has really got a handle on a lot of different things. And it seems like we can stimulate it for depression, maybe headache, also cognitive stuff. So a lot of the stuff that happens in here, it can actually have an effect downstream. So I'm not saying when you stimulate and it goes down to 2-3 centimeters into that area, there's, as you know, brain is connected by all these networks. So that what that would mean is that it will have downstream effects in different networks. And that's where research comes in. That's where we have to find out what networks are being affected, what outcomes are being affected. And so how do we test for that? How do we test what's being affected in the human body after you stimulate the brain? Like I said, we've worked on really heavy things like trying to reduce the number of sessions. So now we do what's called the accelerated treatment. That does like 5 treatments a day, 10 treatments a day for 4 days, and it has really good outcomes. So I did a study, and this was done in 2023, and it got published in Nature. And this was a study that was funded in 2017. It was one of the first studies funded in the VA for veterans with traumatic brain injury doing TMS. So we didn't have a lot of patients, but we were able to assign them to a sham and an active. We had 5 females, 27 males, age was 20 to 69. So altogether about 32 veterans, again, mild and moderate chronic TBI. So they had their TBI like close to 10 years ago. So we split them into sham and active. And then we did a treatment applied to left dorsolateral prefrontal cortex, that area that I was telling you, which is one of the newest areas of the brain. In those days, we did it 20 sessions and we did it in 2 weeks, so 3 sessions a day practically. We also did what's called pre and post, before the study and after the study, MRI. So we were able to look at not just the structure, but also the function of the brain. We also did blood, but I'm not going to talk about the blood right now. We also did neuropsych assessments. So I just want to tell you this, that we also, a lot of these traumatic brain injury patients also had PTSD. So there's also, the PTSD and TBI are very closely related in the sense that they go hand in hand, at least in the veterans. Also, depression can also be very closely related in this population. So we did what's called a neuropsych assessment, which is an assessment battery, which is called VR36, which assesses physical and mental health. So we looked at the subscale of that VR36, and it is known as emotional well-being. We wanted to look at the emotional well-being of these participants before and after the treatment, but also link it to what's happening in the brain. So this is our whole flow diagram in case anybody wants to know what we did to the brain. So it's all here, and you can also read about it in the paper. The results were quite interesting. The results were interesting in the sense that, so the brain you see on the right hand side, that's basically how we depict like what's called a glass brain. So we just want to show you where the network is. So these are all like different types of areas, nodes that we activate, and then the correlation matrix of which area is connected to which area. All you need to know here, the way I teach myself this, because gets very complicated very fast, is that we want to know whether within the active group that received the treatment, were there any connectivity changes, pre and post? And yes, there were. The pre and post and active represent so you have the effective connectivity, which is green and purple arrows show increase and decrease in connectivity, while solid and dashed lines represent excitatory and inhibitory respectively. So what that means is your connectivity is just connectivity, right? It could be excitatory, that means you're actually stimulating the neuron, or it could be inhibitory, that is you're inhibiting a neuron. And this is an important thing to understand, that the frontal lobe of the brain is very big into inhibition. There's a lot of our behavior that we want. I mean, there's tons of times when I want to scream at people when I'm driving or whatever it is. And there's inhibitory stuff that's happening that allows me not to do that. and that's part of the frontal lobe. So a lot of inhibition is part of our frontal lobe. So when you have damage in these areas, it affects your inhibition, it affects your personality. So you know that this is explaining the results a little bit better. You take that connectivity that has changed and you compare it to this, you correlate it to the score of emotional health. What that means is that all of this survived statistical correction, by the way. So what that means is the association matrix between after RTMS connectivity of the active group and their emotional health score. So what we found, this is the result we found. The active group showed emotional health improvement post TMS. So that when we stimulated their brain, their emotional health improved, which was not found in the group that did not receive it, which was the sham group. And this is an important part. When you in previous data, when I've looked at brains, when you look at traumatic brain injury brains, what happens is what we see in connectivity is that the noise increases. So in the different connectivity patterns, there's a lot of random noise. And when you have yes.
Hi, I have a question. And I just say this by way that my son has a severe TBI and he's done a 6-week course of TMS, which we consider to be successful based on pre and post neuroscience testing. I was wondering in this study, you say the group got the TMS and the group didn't. Do you also have any studies where they got the TMS and they did some other mental health intervention to compare it as opposed to just comparing it against zero?
So there have been studies in which they have done. Are you saying together or separately?
Well, if you're comparing, like you could say, well, we're going to compare TMS to an SSRI, or we're going to compare it to a dialectical behavior therapy, or we're going to compare it to nothing, or we're going to compare it to any other number of interventions that you might look at for
yes.
the condition.
So there have been studies that have looked at cognitive behavioral therapy with TMS. They've looked at other kinds of pharmaceutical SSRIs and stuff. And the way we look at it, and that would be for depression. So it's because a lot of people are on antidepressants. So you look at what's called once you are on the drug, then once you have TMS, then you actually respond so well to it that you don't show symptoms of depression for a while, and it's that time that is there that you do not show the symptoms and
The remission, basically.
remission. Yes, sorry, English is my second language, and I still can't sometimes. It's
No, you're just
also
hanging around TBI people, so
yes.
you have aphasia too.
Yeah. So the remission, remission is much less for TMS. Now, here's another thing: a lot of the people who do TMS are non-responders to drugs. So there's a spectrum, right? So you do your drugs, you do SSRIs, and a lot of people are doing Abilify with their SSRI, and then it doesn't work, so they go to TMS. So it's a spectrum, and then sometimes things are so severe that you have to go to deep brain stimulation. You actually have to have things put in your brain. So the way I see it is like it's a spectrum. So TMS does work for some people who are non-respondent to drugs, because your brain also habituates to drugs. Now, you were talking about direct comparison. My patients are on some of these antidepressants, and they don't get off them while we're doing TMS, but they still improve more with TMS rather than without that. We are also doing studies in which we are combining different techniques. So different therapies. So we have TMS and we're combining it with yoga. We have TMS, we're combining it with cognitive behavioral therapy to see which one would be how you can combine different things. And in my view, the reason we want to do that is that it's literally like watering the lawn before you put the seeds in. So you stimulate the brain, and then you put the cognitive behavioral therapy in, or any other kind of thing that you're trying to teach them. So so I think that's how it is. Now I have to get back to my slideshow, so I'm going to stop share and go back to it because I don't know how to get back to it. One thing that we want to know is that the noise in the brain in brain injury seems to go down when you have RTMS, when you are given brain stimulation. And that's what we found, which is, and that is a really important thing, because a lot of my neuroimaging studies, at least 2 or 3 of them, have shown that brain injury, when brain injury happens, the connections, when they break, you have a lot of different, there's random noise that starts happening, and TMS actually dampens it down, which is what we want to see. So that's what we saw. So overall, the activity of all the regions reduced after the neuromodulation, implicated in the improvement of emotional health. Post RTMS was dorsal anterior cingulate, which is a very important area. The results implicates the altered connectivity of DACC with left AI and MPFC, left anterior insula and medial prefrontal cortex as a potential neural mechanism underlying improvement of emotional health, highlights the importance of these brain regions in emotional processing in TBI. And the reason I bring up emotional processing again is because it's a correlate of PTSD. So this is the paper that I've been talking about in case you need to read it or see. I want to take it to the next level, like why I started doing some of this work with TMS, but taking it to the sex difference. Sex difference to me is really important in addressing brain injury and looking at symptoms and then addressing the symptoms. And it's women represent 12% of TBI prevalence in military population, and it is rising. 40% of Americans who have TBI related hospital visits are women. Women with TBI report more depressive symptoms, cognitive complaints, lower quality of life. This is our own data. Women were 1.34 times likely to respond and 1.37 times more likely to achieve remission from MDD relative to men. So our data, the way we gather it, the way we analyze it, it has to be also compliant with the fact that we are looking at men and women. So I had particularly told you that I am now running a Center of Excellence that is funded by Congress, and we are looking at the environmental exposures. That also includes traumatic brain injury. So I ended up doing some work in looking at brain cortical thickness after brain injury in men and women, and I also looked at some deep learning models classified and that are in men versus women when you're looking at TMS responders. So now, before I go into it, I want to ask how much time I have.
You have as much time as you want, and I wanted to ask a few questions about the previous section, but I
Sure.
guess towards the end.
No, you can
Um,
ask now.
okay, great. So yeah, I kind of let these go as long as as long as people are interested, and also you have time, and if people have questions, that's great. There were some questions in the chat, but so first I wanted to ask about, I guess, the methodology and the TMS stimulation because yeah, you had one figure showing the layers of connectivity, networks upon networks that creates the brain. And I was wondering how specific to a specific region can you get to induce that magnetic field stimulated neuronal activity? Like how focused can you get? What size brain
This is a
region?
very, very important question. So, about 15 years ago, people were stimulating the dorsolateral prefrontal cortex as they would ask a neurologist. And the neurologist would do what's called an F beam. They'll go nasal, this, and they will figure out according to generic anatomy where your left dorsolateral prefrontal cortex is. Okay.
Yeah.
You also, what you do is you take the magnet and you put it on your motor cortex and you see whether you can actually stimulate and move your thumb. And from there, you can actually figure out, this is in the old days, where your dorsolateral prefrontal cortex would be, because there's a lot of anatomy. So I did that. I never did that because I'm not a neurologist. I'm a neuroscientist, and I don't have the I know the anatomy, but I don't have that clinical say that, oh, this is where I think it is. So in those days, people started looking at what's called neuronavigation, and that means that you do an MRI before you do the stimulation. You insert the MRI into this machine called neuronavigation machine, which is basically you put a little plastic thing on top of your head, and there's a camera that can actually pick up that, and you have an inserted MRI of each person's brain in the machine, so we can actually then focus the magnet in exactly the position that we know from anatomy of their MRI where dorsolateral prefrontal cortex is. So that's structural neuronavigation. So my first study that I just showed you used structural navigation. 10 years ago, we started using functional navigation. So when we go into the MRI scanner, we can also get another scan called functional MRI, which looks at what's called BOLD response, blood oxygen level dependent response, meaning as areas are being used in the brain, whether they're used for excitatory stimulus or inhibitory stimulus, there's different regions that are lighting up because of the blood. And so we do what's called a resting state fMRI, which is when your eyes are closed or open or closed, but you're not doing a task. And when your brain is scanned during that time and you get all those blood responses, there is about 25 networks that have been established that can be taken out of that scan that are different networks. One is a default mode network, one is a salient network, one is an emotional health network. And so lots and lots and lots of studies have been done to create these 25 networks. And when I showed you those nodes, those are some of the networks that we talked about. When we get an MRI, an fMRI scan of a patient, we can actually figure out from that functional MRI where exactly to the T left dorsolateral prefrontal cortex is in that person's MRI, in that person's functional MRI. And my studies now are not using structural neuronavigation. We're using functional neuronavigation. It takes about a day or two to process because you get the MRI, the T1, the structural one. You get the fMRI, which is the blood. You put it on top of it, then you process it, then you normalize it, and then you send it to either you do it in Stanford or you do it at DC, wherever my guy is doing collaborations. They send it back to us. We insert it back into the machine, and when we stimulate the brain 10 times a day now for 5 days or whatever, our magnet is hitting that spot for that patient that is programmed for left dorsolateral prefrontal cortex. That's how deep we are. That's how accurate we are. We weren't
This
before, but
sound,
now we are.
well, it sounds like you would have to be given the complexity of the brain and also if it's a brain injured brain. So that's awesome that you've taken it to that
Yeah.
individual specificity. And the other question that I had before I read the question in the chat, there's a heterogeneity of people's symptoms. In my podcast, I interview it's like brain injured person, what are you dealing with? And everyone describes very different problems. So I was wondering if you sort the group. I mean, you had a small cohort, but the to sort the people by what their problems are and then see the effect of the TMS may be helpful, but also if you see a blanket level effect across the whole population, then that's also important to see as well.
So,
I was wondering if you had
yeah,
any.
that's also a very good point. Now, there's a weakness in every scientific study, and the weakness is that we how do I say this? We don't represent the population very well. And the reason why we don't is because we have very strict inclusion and exclusion criteria.
Mhm.
So my number one thing for these guys was that guys and women was that men and women was that they have to have a mild and moderate traumatic brain injury. So they have to have that. And after that, they were supposed to have some kind of cognitive problem, and about 80% of them had PTSD.
Mhm.
So other than that, they had a very large number of other problems, right? They had headaches, they had fatigue, they had light sensitivity. But again, the weakness of the study would be that in 32 subjects, you cannot look at everything. We
Of
could
course,
do,
yeah.
so we could do what's called characterizing the response, and we can look at, honestly speaking, if you have somebody who has more comorbidities like PTSD, TBI, depression, headache, they're, they will they will benefit more from this treatment than someone who only has two.
Mhm. That yeah, and that's good
That
to
would
know.
be, yeah.
Yeah. There was a question in the chat about how does the stimulating mean the TMS stimulation release of neurotransmitters help when neural fatigue is from depletion of dopamine in my experience? And so that's that brain injured person experience with figuring out what has been injured in them. But do you have any
What we think is happening is brain derived neurotrophic factor, BDNF, which is increasing
uh
in the synaptic cleft. This increases also with exercise, but with TMS, it seems to be really pushing that forward. And
hmm,
that seems to have a lot of interactions with serotonin as well as dopamine. So it could actually help with that. I have many patients and many friends that I've recommended this to, and they have really felt way better afterwards. And they have, it's dopamine that also rises.
cool. Yeah, please continue the slides and thanks.
So this is a scoping review that we did, and it's a very fast slide that I wanted to show you. We did it to find out what happens when you're actually doing studies and you're reporting the results of neuromodulation and brain stimulation. Do papers actually talk about sex differences? Do they actually mention that this is how TMS response was in women versus men? So we did a lot of a full review, and we looked at 54 studies. And out of 572 studies, I identified 54 studies were included because of several reasons, like English and didn't have this and have that. And only 7 reported and discussed sex and gender differences. So there were obviously more male subjects than females, despite the. But as you know, depression is very high in women, and there's a very large female population that is being treated for depression with TMS. And also headaches. The largest data set for headache is at Yale, and it includes like I think 80% are females. So I think, but the results at that time, this was published in 2020, we didn't see that many people report sex differences. This has changed. People are reporting now a lot more sex differences, and at that time we had made this recommendation to everybody that you need to include things. And the reason why is because and I'll tell you what I've done with this, and the reason why there have been papers published, and I'll get to it. This is very exciting for me, because there have been papers published that show that the thickness of the skull, the thickness of the brain, and the menstrual cycle will have an effect on how brain stimulation will affect women versus men. And the reason I say that, if you talk to any neurosurgeon who's worked with epilepsy, they will tell you that if it's a woman, they time their treatment according to their menstrual cycle. So these are things that, this is the most awesome thing about science now, is that we are not so, unless you're studying like major disease like, cancer and stuff, we are so nuanced now. Like, we know there are things that are happening in the brain that we can look at. When you have a brain injury, you do MRI, different types of MRI, you see changes in the brain. But now you have enough knowledge to do precision medicine. You get a person's MRI, you get person's blood, you get person's personal history. Everything can be personalized and looked at, how you can tailor treatment according to the person. So this is the paper. We actually looked at cortical thickness and diffusion properties. This is very interesting. We looked at what happens to male brain injured people versus female brain injured people. And then we also looked at in the civilian versus the veteran populations. So that's why we have, not civilian veterans. This is controls that are, yes, so that's controls that are non-TBI versus TBI, and then you have female and male within both. And what we found is that when you have a traumatic brain injury, obviously you're going to have cortical thickness reduction. You will have you will have problems. You will see fibers that are sheared in both traumatic brain injury patients, male and female. But what we saw was that cortical thickness was in normal and people who don't have TBI, the thickness of the brain in females is usually thicker, the cortical thickness, the cortex thickness. And after traumatic brain injury, that thinning of the cortex does not go back to its original thickness. It does in males. So in females, that the cortical thickness does not go back to what it was before. And this was published in 2021, and it caused a lot of, it was a really good paper because we looked at these are all women veterans, and they were all from the polytrauma at VA Palo Alto who've had traumatic brain injury. And this is the last paper that I wanted to quickly tell you about, which is the deep learning. That this was done in 2022 before AI became like huge. And we wanted to see how you get response from TMS. And this was done in Iran. They had all these women with depression, and they had gone through TMS brain stimulation, and they don't have neuroimaging there that is accessible for research. So they used EEG, and they used EEG as a way to assess what the response was, how good was it. So they got all this EEG response, and they looked at me and I said, I don't understand what you guys are doing in terms of this. Why don't we apply a deep learning model to it? That is, we basically train the model on some of the data, and then we divide the data, train it, and then we use the rest of the data to see what the response is. And when we did this, we found that the model actually actually fit the males better than it fit the females, and there were more female non-responders than there were male responders. So I think this is an important part, that women seem to be women with traumatic brain injury and depression are more non-responders than males, and we believe that is because the technique was not tailored to women at the time that it was being done. And this is again a paper you can study, but this I wanted to tell you, this is what's happening now based on all the research that I've done. We are now doing a study in TMS, an accelerated study, which is 5 days, 10 treatments a day for women veterans who have headache as a problem. And we are measuring their estradiol so that we can time it and see whether women in whatever cycle they're in, whether they are in the early cycle or whether they're late in the cycle, how it actually can help them in terms of response in headache for TMS. So we're doing the study. We've submitted it. We actually have FDA. We might soon get our FDA IDE, which is basically the exemption for the device soon. Hopefully, they've been talking to us. And we want to do this because we want to do a precision medicine treatment for headaches using neuromodulation for women based on their estradiol. So this is what I was telling you about, is that the field has gone to the point where now we can do precision medicine on this, which is very, very exciting. And last thing I wanted to just say, in case you guys know anybody, I am a lead guest editor for a women's health journal that's coming out, and it's Impact of Military Culture and Exposures on Women's Health. This includes traumatic brain injury. If you guys know anybody, any professors, any academia, anyone who wants to submit a paper, please let them know that and give them my information. I'd love to see papers published in this. And these are my acknowledgements, and that's it.
Thank you, Dr. Adamson. Does anyone else have any questions?
Yeah, I had a question.
Of course, yes, go ahead.
I just wondered how long after the TMS intervention is the data collected? So, for instance, you're talking about your most recent with the headaches. I wonder how, do you follow the patients farther after to
Yes,
find
yes,
out if there's a long-term benefit?
yes. So, pre TMS MRI is done the day before they start their stimulation. And post TMS, there's right after stimulation ends, the post TMS happens immediately after. So that's immediate what your brain is looking like. And then we do 6 months, and then we do a year. I didn't show you the results for those two because if you are in any study, you know the numbers go down. You have people loss to follow up happens a lot, but what in my study loss to follow up happened, but in a lot of other studies we've shown the effects stay in for 6 months and a year, but they usually do need a booster at 1 year.
Mm.
And as far as blood is concerned, so this is, I'm just telling you this because I'm very excited about it. For our study that we are proposing, we haven't started it yet. We're going to be collecting blood every day as they're going through the stimulus. So that's what I do. I haven't talked to you about the blood, but we have collected blood every single day. For 5 days, so we can see changes. Somebody asked me about dopamine and I was talking about brain derived neurotrophic factor.
Yeah, that was me.
The reason I talked about that is in 2017 I collected blood, and there's a paper that we actually are just presented at a meeting last week on that. You could collect blood pre and you could collect blood post, but that's only 2 points and that doesn't really tell you much. So I ended up collecting blood in the middle of the treatment and 4 times. So what ends up happening is you see like pre is low, your BDNF, brain derived neurotrophic factor, then it goes up, then it goes up, and then it stabilizes, and then it goes down as if you collect it at 6 months. So what I'm saying is that you see how treatment can affect, like if you collect blood every single day, you can see how your BDNF is going to keep growing.
Thank you.
Cool.
And thanks for the good work.
Thank you. You're
Um,
very welcome.
Sometimes with brain injury, well, let me rephrase. In my experience and observation of others, I have seen where the headache is like a secondary effect from the specific problems that a person has. For some people, the headache is a primary effect, but let's say your visual system or cognitive system is injured and using it makes things worse. Using it usually leads to a fatigue
Yes,
and also
exactly.
a headache. So I was wondering if you have been able to distinguish
Of course.
for that kind of
So,
headache. Yeah.
so I'm not just headaches. So in traumatic brain injury, we're now distinguishing depression from major depressive
Oh yeah.
disorder. Traumatic brain injury depression is a different thing. TBI depression is a different
You
thing.
talk about Dr. Siddiqui has really good, so his work led me to find you because of the TMS, and he
Yes.
did this last year, and he talks about the benefits of
Yeah, I
TMS. So
just
yeah,
saw him. I just saw him
that's one
last week.
example.
Yeah. So
Oh,
that's
and
one thing.
yeah,
The headache study that I'm doing in women
yeah.
is not related to TBI. It's a headache, the aura headache, the migraine headache, and a lot of it is also related to menstrual cycles.
Uh-huh.
So that's the headache. That TBI headache is a different type of a headache that is more caused by brain injury, and then it's a secondary thing.
Yes,
And
that's what I've experienced, and that's what,
absolutely, yeah.
and I think people don't, in the managing of that, if you don't let yourself get that far, then the headache doesn't happen. But towards treatment and also towards understanding what is happening to the brain injured brain, that's where I think the research needs to focus because that's where the problem is.
Absolutely. And I think one thing you have to also keep in mind, and this is very true for a lot of other things, right? So I was just talking to one of my lab members, and she's a young woman, and she's had COVID twice, and she had
Mhm.
very bad symptoms, and now she has long COVID. So if you have very high symptoms of something, and that's another thing is like in the old days, nobody really cared about a mild or moderate TBI. They won't even send you to a CT scan. They're like, go home, go to sleep, you'll be fine. And I just have to be. We're too aware now. We're too connected to the world. We know too much. We can't let that happen.
Some people are, some people are not. I do these interviews with brain injury people, and still people tell me that. And then other people are in the places where the good centers are good people, or the culture has shifted, and then they are actually getting great care. So it's the discrepancy makes it almost not worse, but it's like frustrating because it's like some people are really getting that understanding, and some people are. I had my TBI in '99, and it was like, well, I had a severe TBI though, so it was on the radar. I had a
How
subdural hematoma.
how old were you?
I was 18. I saw that you went to UC Irvine.
I did. I did my
I did as
bachelor's
well.
there. I
Oh,
did my women's studies and neurobiology, and
yeah.
I was fresh from Pakistan. I had come here from Pakistan at that time, so.
So I was there too. I did third week of my freshman year, my head was crushed in a car accident. Severe, I had a subdural hematoma, ICU coma, then induced coma. I had a long, crazy, yeah, but I think the severity scale is just a deeper hole. And as I got better and learned to talk to people about it, a lot of it is in the mild and moderate range. But in the beginning, I wasn't like that. One other question I had. Oh, with the stimulation, and so you mentioned the 26 networks in the brain. I never heard that number, but
It's not 26, it's more.
or
So in we I mean depends who you're talking to, right? So
yeah, yeah, because
I
I've
mean
always
I'm just gonna
yeah.
ask I'm just gonna pull it up on Google just to show you. So because
Fair enough.
that's what we do now. So let me just fMRI connectivity networks. I mean this work has been things
Yeah,
have
yeah. No,
changed,
well,
but
aside from that number, or given whatever that number is, it is a number. It is quantifiable. How many brain regions have been tested with TMS? Like, have you done other stimulation of other regions? Have you seen other,
oh,
like,
that's a very
yeah.
important, that's a very, very important point. So let me just,
Yeah. And I was just saying, like, in
so
that
here it's
general, there's a
saying,
number of networks. Yeah.
so here is like 17 networks, right? So 7 to 17 networks. But if you look at it like from the perspective of Mike Grecius, then he would say 25 networks. It depends on who you're looking at. So there's a history and future. And one of the things that I wanted to particularly also say is that I've focused on dorsolateral prefrontal cortex, but there's a lot of people who are doing parietal. There's people who are doing motor cortex. There's people who've done other areas as well, and it's again outcome based. So motor cortex sometimes is used for headaches.
Yeah.
Parietal sometimes is used for memory. DLPFC is used sometimes for PTSD. So there's different networks for different things, but what DLP, left dorsolateral prefrontal cortex, is what's also FDA approved for those three things that I told you about. Yes, is it Moz?
Yeah, I had two kind of comment questions. One, thank you for bringing up the menstrual cycle is a huge effect for those with TBI. For me, it reduced my capacity and cognitive abilities and everything to a great deal. That they put me on low estrogen continuously, which gave me cancer. And
Oh goodness.
the problem with low estrogen, it didn't really help because it raised my progesterone, and I determined that it was the progesterone that is depleting, that's causing the difficulty with the during the menstrual cycle. But of course, during that time, now they're allowing people to have estrogen again. But during the time that this was, 10 years ago or 20 years ago, they weren't allowed to give me estrogen, and they didn't believe me anyhow. But anyways, the next thing was that I was in a study in 1990s that used EEG to stimulate the brain. And it was a person that was what's the P uh, school in New Jersey, Princeton. Okay, he was from Princeton. He was a neuropsychologist. And what that did was instantly, like they used Pac-Man. And so all I had to do was sit there, and they like set parameters. And when I hit those parameters, the Pac-Man would move. And instantly it would make me agitated. This was in San Francisco, so I'm familiar with Stanford and everything. But it was, I almost didn't finish the study because each time they, I would get agitated. So they changed the parameters that was similar to autism, because the woman had the clinic, set that clinic up for her son that had autism. So anyway, so that was one of the questions I had, because you're stimulating the brain. That EEG was to stimulate parts of my brain, and it was contrary to benefit.
Right. So again,
But yet they
yeah.
all they tested me was on cognitive ability, and so they pre-tested me on that, and afterwards, and I improved cognitive ability. But I think that was just rehearsal of the test, and that's the only reason why I had a upgrade, increase in that. So
that's very interesting. I'd love to see if there's a paper on that old study, because what they do for EEG is I have an EEG machine that's 264 electrodes, and I record from it. So you wear this EEG cap and you record EEG.
Right.
If you're using it to stimulate, then that means you're passing a little bit of current to it.
Okay.
And I don't know how they do it. I don't know. Maybe I'm not.
It wasn't that they were stimulating my brain. What they were doing was they were setting parameters, recording parameters, and when my brain hit certain parameters, that was intentional.
Biofeedback. So they were doing biofeedback. Okay, I got it.
Exactly. So it was, and it was a Pac-Man. So the mind is.
Right.
They said the mind's always wanting to win. So whenever it hits those parameters, and I see the Pac-Man moving, then it encourages the brain to continue in that way. So that's how it's stimulating it. Okay. And it was so wild that I would instantly become so agitated that I would jump out of my chair and want to just get out of there and never come back.
That's very interesting. I have not heard of that study, but thank you for sharing that. Thank you for sharing your experience. Okay, HK, yes, and I can only do one more question because I have a meeting at 11.
Is this only in the research stage, or is this available clinically to actually get help for brain injury? I'm 4 years out, but I don't know if this is only in the.
Did you get Did you get a severe brain injury, mild, moderate? Or?
I have a mild one that completely changed my life. I'm living in state housing. I can't function beyond.
Which state are you in?
Seattle. Washington.
Yeah, so just go to your provider and tell them you want to do RTMS. It is clinically available, and your insurance should be able to pay for it.
RTMS, and even on Medicaid, because I feel like I get bypassed by a lot of things.
You need to ask them, because it is completely available and insurance pays for it. It's expensive, but outside of that, but I would definitely ask. It is something that people are doing for depression, for OCD, and a lot of doctors are doing it off-label for different problems. So I would explore that.
Okay, and then real quick, because I know you have to go. Does it re-stimulate the connections that were lost? Is that kind of what it's doing?
That's kind of like what the idea is. But remember, it's like the whole idea is that you have an injured brain, so you have lots of
finding new routes. I mean, that kind of thing.
For putting in a lot of stuff into that cleft, so that you can actually have neurotransmitters that can help. I like to say it's making the juices flow. That's really how it works. So
there's a lot of.
I think that's accurate.
Yeah.
Because I'm pretty much homebound, couchbound because of this. So I'm trying to. No, that's okay. I'm just trying to figure out other therapies that can move me forward.
You have to ask.
Yeah. And you said it's RTMS. That's what I call it.
RTMS.
Yes.
Okay.
Transcranial Magnetic Stimulation.
Gotcha. Okay. Thank you. Thank you so much,
Dr. Adamson.
Thank you. Good luck with all your wonderful confidence, and work towards getting better.
Thank you.
Yeah.
Thank you very much. Okay. Bye-bye.
Thank you.
Bye.
Bye.
Thank you. Yeah, thank you very much.
Thank you.